Good evening, everyone. Thank you for joining us tonight. Welcome to the Avexia webinar series. Our topic for tonight's special webinar is a paradigm shift in cardiovascular risk assessment. My name is Joanne Iverson. I am the Director of Client Relations for Avexia Diagnostics and will be your host for this evening. Tonight, I have the distinct pleasure of being joined by an exciting guest, Dr. Regina Drues, who will be our presenter for this webinar. Dr. Drues is an integrative cardiologist, a physician executive, and a digital health entrepreneur. She is the CEO and founder of the Holistic Heart Centers, a precision cardiology practice and management services organization. Dr. Drues is the creator of Fit in Your Genes, a proprietary program based on functional medicine principles for patients seeking to optimize their cardiovascular health, wellness, and vitality. Dr. Drues completed her MD at the Cornell University Medical College in 1995 and her internship and fellowship training at the New York Presbyterian Hospital in 2001. She is board certified in cardiology and cardiac imaging, including nuclear cardiology, cardiac CT, and echocardiography. She is a national expert in cardiology and holds a variety of leadership positions. Dr. Drues is a certified functional medicine physician. In 2021, she completed her executive MBA and Master of Health Policy and Research dual degree at the S.C. Johnson School of Business Management, Cornell University, and Weill Cornell Graduate School of Medical Sciences. Joining Dr. Drues tonight will be Dr. Wayne Sedano, our Director of Clinical Support and Education at Avexia Diagnostics. Additionally, Dr. Sedano is the Director of Integrative Medicine Education for the College of Integrative Medicine and lectures and teaches internationally. Just before we begin, a bit of housekeeping. We encourage participation. So if you have a question, you may submit your questions in the questions field in the right-hand area of the interface. We will answer submitted questions towards the end of the presentation. If your questions are not answered this evening, you will surely receive an answer by email within a day or two. In addition, the slide deck is available in the handout section below the questions area. So feel free to download that and have that. Without further delay, I will now turn the webinar over to Dr. Drues.
Thank you so much, Joanne, and thank you to the teams at Boston Heart Diagnostic and Avexia for giving me this opportunity to present exciting developments in the cardiovascular risk assessment. Our focus today will be specifically on advanced testing and its role in redefining the risk estimate for patients who are presenting themselves and seeking heart health care and heart health optimization. And we specifically will focus on monogenic testing and the opportunities that we have to pinpoint relevant genetic variants that influence our patient care, as well as polygenic risk scores, an emerging area that is now available in the clinical domain to help clinicians and patients further refine their risk prediction. If you are involved with cardiovascular patients, you may have realized by now that advanced cardiovascular testing is really an opportunity for what I would call a precision cardiology pathway. It's truly a chance to figure out what are the root causes of dyslipidemia, systemic and vascular inflammation, and how those redefine or help us to refine the cardiovascular disease risk, especially the risk of cardiovascular events. If you have been following some of our presentations in the past, I recently gave 3 webinars under Boston Heart Diagnostics, introducing physicians to the concept of atherogenic lipid phenotypes or ALPs, explaining how those influence or get influenced by inflammatory pathways, both systemic and local inflammation, by local inflammation implying vascular inflammation, as well as giving a window of opportunity to understand the role of monogenic and polygenic risk. But you may ask yourself, why do we actually need this? If you look at the medical literature, if you look at the guidelines available in the cardiovascular medicine and in primary care medicine, the guidelines continue to be fairly centric to LDL cholesterol. They are predicated on measuring LDL cholesterol. However, we have known for quite a while, and this is a very nice review from Dr. Peter Libby of Harvard Medical School, that there is a lot of so-called unfinished business in cardiovascular medicine. We know that even with the best lipid-lowering therapies across the range of trials, whether they're secondary prevention, primary prevention on high-risk individuals, the reduction in major coronary events defined as non-fatal myocardial infarction or cardiac deaths is somewhere on the order of 30%. I'm of course speaking about relative risk reduction. And what Dr. Libby and his colleagues at that time called is what they deemed as a residual risk. And residual risk is actually quite sizable. Very often when I speak to patients and when I train practitioners, I help them understand that while it's called residual risk, it is more like a major risk, because if you look at its impact, the approximately 60 to 75% of the major cardiovascular events are not being accounted for through the reduction of LDL cholesterol. And so that presents us with an opportunity to understand a little bit deeper what are these factors. And so the cardiovascular risk factors that go beyond the basics, such as advanced lipoprotein analytics, looking at inflammation and endothelial function, looking at what is called metabolics and metabolomics, two very interesting emerging areas, as well as really being able to understand the impact of genetics. And a lot of development and research is actually ongoing in all of these areas, even though lipids may be one of the well-known areas and well-characterized. There's still new things being discovered, for example, the impact of lipoprotein little a, and so on. If you have attended previous webinars, you may have been exposed to the concept of atherogenic lipid phenotypes, or ALPs. And those are really important concepts. The atherogenic lipid phenotype is really our opportunity to understand what actually is shaping dyslipidemia as well as cardiovascular risk for our patients. For example, we have known for quite a while now that ApoB, which is a measure of the overall atherogenic cholesterols and the particulate burden that these atherogenic cholesterols bring into the vascular system. We know that it's more predictive of cardiovascular events than LDL cholesterol. We also know that if we look at the combination of ApoB, triglycerides, HDL cholesterol, and small dense LDL cholesterol, we could put these together as pieces of the puzzle to really focus on something called dyslipidemic triad. And dyslipidemic triad is fairly easy to understand under a situation that are occurring with insulin resistance. There is increased production of free fatty acids. As the free fatty acids travel to the liver repackages those into triglycerides and of course creates ApoB, which are coating all the atherogenic lipid particles that are non-HDL. So there's a one-to-one relationship between ApoB and the burden of atherogenic lipoproteins. But because these particles are triglyceride rich, they become substrates for several specific enzymes, including lipoprotein lipase, cholesterol esterol transfer protein, and so on. And as a result, they undergo very quick enzymatic action in the vasculature, giving us small dense LDL as well as a small or low HDL, because HDL gets stripped of its protective lipoprotein coating, giving us nascent HDL. And I encourage you to think about it actually in distinctive atherogenic lipid phenotypes. This was described very well in 2022 in the Journal of American Heart Association, where investigators have looked at ApoB and triglyceride patterns as a guide to what might be the underlying physiology, including genetic predispositions for the patients. And obviously we have a normal situation. We also have a situation of normal triglycerides and high ApoB, which is typical of familial hypercholesterolemia, whether it's monogenic or polygenic. We have a situation of familial hypertriglyceridemia, where we have high triglycerides but normal ApoB. And probably the most common is familial combined dyslipidemia, where both high triglycerides and high ApoB are detected. And probably the least common is so-called remnant dyslipoproteinemia, or type 3 hyperlipoproteinemia, that is genetically determined due to alterations in the ApoE gene. You also probably are familiar with atherosclerosis and its strong association with inflammation and this concept of a vascular tunnel. The fact that inflammation, oxidative stress, and vascular immune response, all of them are depicted here. You could see that early on, the oxidative stress as it builds leads to disease initiation and plaque growth. And of course, there is a response from the immune system, attempt to heal and sort of to seal the plaque, if you will, to fix the vascular wall, and in situations where this attempt is progressing down toward an acute event, we could potentially find the hallmarks of the acute event, even in individuals who are currently chest pain free. So this is an important understanding of what we actually have. So I thought I'll bring in one of my initial cases just to give you a bit of a clinical perspective, because I have no doubts that you know about a lot of the markers that I already mentioned, and potentially even checking those markers in your patients. But I wanted to give you a flavor of when one could be with the clinical application of some of these more advanced tools. So this is one of my patients who is only 36 years old, who she went for a routine physical, just a typical annual physical that people get, and unexpectedly was found to have elevated cholesterol. It was not a significant elevation, it was actually very mild. And she was advised by her physician to really implement lifestyle changes. And she, of course, is very interested in lifestyle changes and lowering her levels, because she does understand that she certainly is at risk of cardiac-related disease. What's interesting is that she's overall a very healthy patient. Her diet is limited in animal protein. She exercises. She doesn't eat red meat. And she actually goes for long walks. She does meditation. And an interesting part of her history was that there's actually no family history, but there's some history of aortic valve issue in her grandma, but that issue occurred when, grandma was fairly old, which again is not very rare. It's actually very common. So the laboratory workup there was to get her baseline blood biomarkers, and actually one of the testing approaches here included dry blood spot testing from Boston Heart Diagnostics. And I also looked at her polygenic risk scores and her GI balance. The GI balance is again a Boston Heart Diagnostic kit that shows us specific microbiome patterns that are relevant for cardiovascular disease. And we repeated those biomarkers at a 6 months mark to see where her progress was. If you're not familiar with dry blood spot, there are actually quite a few of them that you have available. They're all a little bit different. You may want to build perhaps a custom panel, or potentially could find that one of those panels or couple fit your customer needs. I usually stick with cardiometabolic, either enhanced or advanced, but there could be other utility based on your practice setup. And so her dry blood spot, this was certainly very informative. You could see that we hit some really important markers. Obviously, we expected her total cholesterol to be elevated because that was the whole reason why she was referred. But you could see here that her HDL cholesterol unexpectedly, this is only a 36-year-old woman who has normal hormonal cycles, and as I mentioned before, is very healthy, very health oriented. This is a fasting laboratory specimen. So you see her triglycerides are 124, fasting triglycerides are 124, her ApoB is elevated. And sure enough, she has some elevations in small dense LDL cholesterol. So taking together, that does go with this lipidemic triad, as well as elevations in lipoprotein(a). And now all of a sudden, her history of a grandma who had aortic valve disease is becoming a little bit more suspicious because, as you may know, aortic valve calcifications, especially early aortic valve calcifications, are one of the features of patient with elevated lipoprotein(a). She also has a lot of inflammation on board, and her C-reactive protein being 4. So I did mention genetic profiles. This is actually a pathway-specific monogenic and polygenic genetic profile from a partner laboratory with Boston Heart Diagnostics. And you could see here is that she has certain single variants. This is what you see up there, where it says variant hypercholesterolemia. So ApoB, ApoE, so she's ApoE4 heterozygote. Now, none of these variants by themselves are enough to explain her LDL cholesterol ApoB elevation, but taken together, they will give her a high risk, and that's exactly what you're seeing. You're seeing that it's not a situation of combined hyperlipidemia, but it's a situation of hypercholesterolemia, and most of these hypercholesterolemia cases or patients are associated with polygenic risk scores and not your classic familial hypercholesterolemia syndrome that we learned about in medical school. And of course, she has a variant that identifies her as high risk for lipoprotein(a). And this is very significant because even though she's only 36, and we don't have a specific treatment for lipoprotein(a), we do have aspirin, and baby aspirin is a preventative measure in the ASPRI trial, has been shown to be of benefit to older patients with genetic predispositions to lipoprotein(a), including polygenic predispositions. So while this patient is younger, we could certainly use baby aspirin off-label in this patient. She had undergone our Fit New Genes program, which is proprietary program for holistic heart centers. And you could see that, she has begun to shift significantly in her risk profile. She dropped her C-reactive protein into good range. At less than 1, she'll be optimal, but at less than 2, she's considered in the optimal range by the cardiovascular clinical trials. Her lipoprotein(a) had a mild decrease, although I would not, hang my hat on it, because lipoprotein(a) in a genetically predisposed individual will have variability almost regardless of what you are doing. You could see very mild decreases and some fluctuations in her ApoB and her total cholesterol, but certainly resolution of her dyslipidemic triad, normalization of small dense LDL cholesterol, improvement in her ratios, and of course improvement in her homocysteine, although vitamin D still needs work. So let's switch gears a little bit and use this patient sort of as a starting foundational clinical case to really help us understand what are the roles of these genetic pathways, and should you or should you not incorporate them into your assessment, and at what point will you be incorporating them. And I think it is important to get some language, some vocabulary in our exchange, so that we all communicate the same way, right? So when we talk about single nucleotide polymorphisms, or SNPs, and you had seen a few, you had seen the patient that I just presented to have ApoE4 heterozygote, meaning that she has one copy of the SNP that is E4, another one is E3, and you saw the same for her ApoB gene and for her Lp(a) gene. So those are so-called genotypes. What that means is that the laboratories are looking for a specific variability in single nucleotide that is associated with a clinical factor or disease. And so you can regard that as monogenic pathways. And so what we also know is that genomics globally, if we sort of zoom out of it, is the study of genes, their functions, and their related techniques. And there are different types that we can get assessment of genomics. We can do something called whole genome sequencing, which is basically everything that comprises our DNA, whether it's us or microbes, and it is the most comprehensive method for analyzing the genome. We could look at the exome, and exome are specifically the protein encoding parts of the genes, and they are helpful because they do contain a large number of relevant mutations. But of course, if you're only looking at these protein encoding parts, you're not looking at the parts that could be relevant that are not protein coding. And so whole exome sequencing, also referred to very often as next generation sequencing or NGS, is actually a more efficient method for identifying disease-causing mutations. Because it is a look at these protein coding parts of the genes and accounts for about 1.5% of the full genome. And this is really what genotyping is, right? So you can look at it, and that's what genotyping is, while whole genome sequencing is actually looking at everything together. And so there are also some other interesting kind of language, or if you will, definitions here. So for example, this is a structure of a SNP that is coding for C-reactive protein. Now, as you know, there are patients who genetically are more likely than other patients to have a higher C-reactive protein, which is associated with vascular events produced in the liver, but also could be produced by atherosclerotic plaques themselves. And so the C-reactive protein in the panel A, what you're seeing there, it consists of 2 exons that are comprising decoding regions. Those are shaded in this dark blue. That's where the codes are, protein coding region. And then the other ones, which are non-coding, have a medium shading. And then the other ones, which there's many more, we're not quite sure what potentially they might be doing. We know that there are some regions that are adjacent to the main SNP, and and that's what you kind of see it here, right in the middle of the screen. And so what happens when you start sequencing this, as you could imagine, there could be a number of different permutations. And this is because you have 2 exons and you have these multiple regions, coding regions, non-coding regions, and other common, variabilities that we're not quite sure, what exactly they may or may not be doing. And so when you are sequencing this, you could have different permutations, and this is what typically is known as the haplotypes. And so what ends up happening then is that we are hoping that when we are able to do more than just exome sequencing, and that we're actually able to do a whole genome sequencing, we're able to get an idea what else we have that influences this gene expression, right? It's not enough just to have a gene. Something makes it either do its thing or not. And we know that beyond the SNP genotyping, we actually have an expression of this gene, so it has to generate messenger RNA, and that in turn induces various activities in other genes, in other SNPs, of course, the protein production and protein signaling. So it becomes fairly complex and obviously an area of very intense research. And we ideally would like to have this type of a situation. Here it looks very nice and neat, but it's certainly very difficult to achieve. We'd like to take a patient serum or some sort of a tissue sample and do our genotyping, which what we can do now, but also do the expression profiling. So that's our mRNA data, look at proteins and the metabolomic components, put all of this together, feed it in with the influences and the clinical scenarios, the medical history, the family history, environment, our existing clinical risk scores, feed it into a database, and go through the statistical modeling and somehow arrive at a more personalized precision score. So this is the ideal state. We don't have that state now, but what we do have is that we have certain things that could help us. For example, In the monogenic arena, you can get genetics, and you can actually get it off your dry blood spot testing, because it is included. You could get something that will tell you if a patient is statin sensitive, what the ApoE status is, how likely a patient is to respond to clopidogrel, which is one of the very common cardiovascular medications. You could also see information about the benefit of aspirin, so that's our Lp(a) genetic sort of marker, as well as some other markers that have to do with hypercoagulability, methylation, atrial fibrillation, statin benefit, and so on. And very often where it could be clinically helpful is that patients who are recommended statin medications and who actually may benefit from statin medications are often reluctant or resistant to the idea of being on a statin medication. And it does help to know if a patient is likely to develop statin-associated myopathy and what their specific risk might be, because then there's a lot of opportunity to actually give them a different statin regimen and also give them some of the supplements they potentially may have. And so you could see here that, if you go ahead, it's called SLOCO1B1 genotype, which is genotyping. You could reassure a patient, and even if you are starting statin slowly, just reassurance and being able to know that they are a normal responder may help them to understand, the regimen and be more compliant with the regimen, or may alternatively point you to a different type of medications, or potentially how to dial in the supplementation to help these patients along. And there are a couple of other genetic types that are relevant. Obviously, we know about methylation and hyperhomocystinemia, the fact that it has increased association with cardiovascular risk, venous thrombosis, peripheral vascular disease. The most well-known player in that arena is our MTHFR gene, but we also know that methylation is not just MTHFR gene. It's a very complex series of reactions, and fortunately we could actually measure some of the clinical metabolites of this genetic and potentially do some genotyping as well, and that's what a lot of commercial direct-to-consumer entities are doing, and that's essentially where we are. So you could get, for example, the MTHFR genotype with the Boston laboratories. You could also get things that are a little bit more relevant to clotting, to a detox pathway, especially if a patient is clopidogrel, which is of course brand name is Plavix. And I already mentioned how important it is, and this was a case with our patient, how important it is to actually see if there is a genetic predisposition to elevated lipoprotein(a). Approximately half of elevated lipoprotein(a) cases do not have an identifiable genetic variant, and so this is not quite clear. What does it mean for these patients? And a lot of information that you have right now is coming from the ASPRI trial, which I did mention. It was a double-blind placebo-controlled trial that looked at low-dose aspirin. It was an international trial, so it was both Australia and US. So the aspirin dose was a little bit different than what we use in the US. It was 100 milligrams. And the endpoint was disability-free survival, or a median follow-up of 4.7 years. And study enrolled 19,000 patients. They were 70 years of age in Australia, 65 years of age or older for US minorities, but they had no prior history of vascular disease. They had no angina, they had no stroke, they had no high blood pressure. So they really were a quite healthy group. And so the endpoints, of course, were traditional endpoints, major adverse cardiovascular events, fatal heart attacks, of course, non-fatal heart attacks, ischemic strokes, both fatal and non-fatal, bleeding events, including the major hemorrhages such as intracranial hemorrhage, for example. And what you're seeing here is that for those patients who were carriers, and this is genotyping, they definitely benefited, right? So the overall group was kind of neutral. There was a zero net benefit. The risk of bleeding was pretty much equivalent to the risk of benefit. So there was parity. So the conclusion was from the trial that, as a group, there was really no benefit to this low dose primary prevention with aspirin. However, when investigators looked at the patients who had genotypes, and not all of them did, but some people did, approximately 3,000 people out of 12,000 had the genotypes determined. And so you could see that those who were genotyped as a specific SNP carrier actually did have a benefit from aspirin. It prevented approximately 8 events per 1,000 person years. And patients who did not have this specific SNP, but they had others that were smaller in their effect, but when added together, they were forecasting a higher risk of lipoprotein(a) versus the reference population, and that was divided by quintiles. So this is what we know as polygenic risk scores, and we're going to dive into them in a minute. You could see that these patients also had a benefit, approximately 2% per 1,000 person years. I'm going to skip KIF6. It is an interesting marker that in some studies have been shown to signal a better impact in coronary heart disease events with a statin drug, but in other studies it wasn't as apparent. And of course, you probably know about 9p21, which is the endothelial dysfunction gene that is associated with increased vascular abnormalities, although because it's so common, it's really difficult to know, what its clinical utility is, except maybe assessing a patient for subclinical atherosclerosis. And if you recall, I assessed my 36-year-old patient, actually, the calcium score, and her calcium score was 0. There are, of course, other genetic markers that have to do with other cardiovascular issues, such as, for example, propensity to atrial fibrillation, whether from the ground up, and essentially it increases the risk postoperatively for CABG as well. And so the ApoE as well, probably something that your patients are asking for or potentially may already have received. We talked about it briefly in the atherogenic lipid phenotype discussion, where I said that certain variations in ApoE, and specifically E2E2 homozygous state, creates a potential for type 3 hyperlipoproteinemia, although it's fairly rare. Most physicians and patients are aware of ApoE4, which may require more aggressive lipid-lowering therapy, including therapy that has to do with statin medications. So what are the polygenic risk scores, right? You heard me mention it a couple of times, and let me just take a quick sip of water. And so polygenic risk scores are a rapidly emerging area, and actually I was asked recently if they're ready for prime time, and I do believe they're ready for prime time, but of course with a caution. And what made polygenic risk scores possible, of course, is genome-wide association studies. So there is a lot of good information on the genome-wide association studies website. As you know, this was sponsored by our government. There is a site called genome.gov, and you can find a lot of interesting sheets or even simple things that you can potentially use with your patients to explain it. But let's go through it together. So what I have presented up until now, except when I discussed the polygenic scores for lipoprotein(a), were things that you're familiar with, right? You know that if we study certain individuals with disease, let's say individuals who have familial hypercholesterolemia, we know it runs in their family, that, let's say mom or dad or child were born with LDL cholesterol, which is 300 or so. And so these individuals, we know that there are certain SNPs, certain genotypes that are associated with these diseases, and we can have 1 or 2 or 3. For example, in classic familial hypercholesterolemia, there are 6 different genotypes. So if you send it to the lab and you say, I'm testing for familial hypercholesterolemia genotype, then we're really testing for those 6 specific SNPs that we know have association with familial hypercholesterolemia. But what about individuals without disease? We now have the chip. Yes, again, these are the chips, and just as AI is in need of chips, a lot of AI algorithms and machine learning algorithms, computational algorithms actually were made possible for this multi-million additive genotyping that could let us know what actually is the situation if we follow those individuals, let's say, prospectively. And so we could add multiple SNPs together, and each of them by themselves could have a very minimal impact. But when you start adding them together and you look at a population of patients and you see how those combinations pan out, you could actually figure out whether or not the population who is in front of you is at an increased or high risk of a specific disease. Now, it's important to know that, to note that high risk doesn't mean 100% the person will get a disease, but maybe it will usher in some preventive, some screening measures, and some additional treatment. And you will find this on cdc.gov. And this is a very nice illustration, because we know that if we add these SNPs together, and there are investigations that are looking at various SNPs in various clinical trials, and you start adding them together, you end up with a normal distribution. And certainly some people in this higher risk category of a normal distribution will be at higher risk. And what was interesting and probably unexpected is that this is not benign, because we have our clinical risk, of course, something that's been tried and true, and the understanding of it has been developed for many decades. And then if we add polygenic risk into it, we actually see a redefinition of what the combined risk is. And we could potentially, especially in this intermediate polygenic risk group, this is a very diverse group, because some people in that group may not be at a high clinical risk, or maybe at a high clinical risk, but because they're intermediate, they will actually do better, for example, than the clinically risky individuals with high polygenic risk scores. And one could even build an interesting concept and say, well, what is the difference then if I'm doing the genotyping, which is polygenic, and I just spoke a few minutes ago about polygenic variants for familial hypercholesterolemia and monogenic variants. So, typically people would do these monogenic variants and would say, well, this is what we know, right? But here, what is interesting is that if we take individuals with this monogenic familial hypercholesterolemia, right, so they either have familial hypercholesterolemia monogenic variant or they do not, right? Because it's binary. It's one genotype and one to 6 SNPs. And then we say, okay, what happens if we now look at the polygenic scores? And you could see that here in this orange line, and each of these is actually an individual aggregation of data. And you could see that, and it's arranged based on percentiles. So if you look at these scores, individuals with familial hypercholesterolemia monogenic variant differ in their genomic risk for coronary artery disease depending on polygenic risk scores. So those of them who have low polygenic risk score are sort of similar, and you can just draw the line here, to those who don't have any familial hypercholesterolemia usual monogenic variants but have high polygenic score. And actually the high polygenic score is about much more prevalent, at least 20 times more prevalent than the familial hypercholesterolemia monogenic variants. So all of a sudden it opens an opportunity for us to find patients who truly may benefit from appropriate interventions. And this is why I came back to this slide, just to show you that this is exactly the style of thinking that's been done in the ASPRE trial, right? They've gone from monogenic Lp(a) to a polygenic score. Another important part of it is really trying to understand, how can we apply certain things which are nutritional, right? For example, there's been a paper very recently in 2021 that have looked at the benefits of ketosis, about the bioenergetic and pleiotropic effects of ketone bodies in the various areas cardiovascularly and cardiometabolically where those could be of benefit. But then we had a study that was actually discussed in 2023 at the American College of Cardiology annual meeting that looked at keto-like diet. And, obviously these were dietary recalls, which is always tricky. But what they looked at is that what actually was happening. And so they figured out that these keto-like diets were linked to high risk of heart disease and cardiac events. And it was bad for heart health. And that it was essentially based on self-reporting, but it found increased levels of LDL cholesterol, so-called bad cholesterol, and so on. And you could see why this may occur, because depending on these polygenic scores and polygenic predispositions, the low carbohydrate, high fat diet may not be appropriate for those patients. So while monogenic risk should be investigated if you are thinking of interventional diets such as ketogenic diet, especially for familial hypercholesterolemia. But remember that polygenic risk scores identify 20 times more people who could be at risk for coronary artery disease, who also may not do well with the ketogenic or let's say alternative high carbohydrate diet. So I thought I'm going to show you some representative cases of this polygenic risk scores, because this is always kind of an area of investigation, and how to apply it clinically is not always clear. So I call it, let's take PRS for a spin. And this is a situation of a patient who is 37 years old. It is a male patient, and this patient has no history of anything, essentially. This is a routine blood work that was obtained on a physical exam, sort of very similar to the blood work that my other patient had, a 36-year-old woman. And there are some areas there that certainly could improve, but there is nothing super concerning. The direct LDL cholesterol of 103 is something that should readily go to less than 100 with a little bit of lifestyle effort and so on. But should we stop there? Maybe, maybe not. So this patient actually had a polygenic risk score assessment. And again, I do not know the full history. Let's assume that they may have had family history. Maybe they were just looking out for themselves. And what are we seeing here? We're seeing here is that this patient's polygenic risk score placed them in 88th percentile for age and gender, and they confer a greater than 46% lifetime risk for coronary artery disease, which is 3 standard deviations above the reference population. And this is a very large reference population, actually, from UK Biobank and other studies. And this is a specific report from Boston Heart. And you could see here that this polygenic risk score is 1,926,521 genomic variants. So it's not a single SNP anymore. It's almost 2 million SNPs all added together using computational biology. Now, why do we care? How would it change management? I would actually ask for cardiac imaging for this patient, right? So the stress test here is not going to help because likely they're asymptomatic and in good shape. Obviously, if they have symptoms, they should go and get stress tested, but this is where I would call for subclinical disease. And we have studies right now. For example, we have a study, recently a study that was imported in JAMA that cited increased obesity and diabetes among young people ages 20 to 44, and it was worse for minority patients. And as hyperlipidemia itself was declining, hypertension remained the same, so we haven't really controlled for risk factors. And then there was another very interesting study from Denmark, which was a prospective observational cohort that was identifying subclinical coronary artery disease in 9,500 or so, almost 10,000 asymptomatic patients. Those patients were in their 40s, a little bit older, and they undergone cardiac CT angiography, and the results were shocking. So half of them did not have any coronary artery disease, but 36% had non-obstructive coronary artery disease, and 10% already had obstructive coronary artery disease. They followed them for 3.5 years, and they determined that the risk of MI was increased in those people who had obstructive disease, especially if it was extensive, in all major coronary artery distributions. And these patients who had the highest risk of obstructive extensive coronary atherosclerosis were subclinical patients. So they had 12-fold higher risk of major adverse cardiac events, including specifically myocardial infarction, that had 0 symptoms. And so the risk of composite endpoint of death of myocardial infarction was increased in these people with extensive disease. And what's interesting is that it was increased regardless of degree of obstruction. Obvious obstructive disease was worse than non-obstructive, but it was increased, period. And while this study mostly looked at the Caucasian individuals because I guess that was the sample from Denmark, it's certainly very worrisome, right? And you know that probably some of these patients who had this extensive disease were patients in the high PRS group. And so the high PRS increases the lifetime risk of CAD, and that's why it's important for us to be vigilant. Let's go a little bit in reverse. So this is another set of data, a different patient, and here I decided I'm going to show you the polygenic risk scores first because I don't want you to be biased by the blood work. And so this is fairly normal. This is a person's, we're looking again at the same almost 2 million SNPs, and we're looking, and it's a woman, she's in her perimenopausal, menopausal years, and we're looking to see if there is any risk. And you could see it's very, relative risk is not really elevated. It's where the population is at. And these are the labs, right? So will you actually run for the statin drug? Probably not, because most likely this has to do with the hormonal issues, potentially thyroid, and things of that nature. So the Holistic Heart Centers, what we do is that we have built a precision cardiology pathway while we're taking the history and the records in the prior test, and we are laser focused using something called Heartwell Toolkit, which is a collection of biomarkers, genetic and epigenetic data. And I'm happy to be collaborating with Boston Heart Diagnostics on including some of their panels into the Heartwell Toolkit, and we provide this personalized action plan for heart and vascular health. Obviously, it is a tall order. A single individual, even a group individuals, will not be able to do it. We need reams and reams and reams of data because it is very complex. You know, our genome gets environmental stimuli and so on. And there is actually something currently called eMERGE Network, which is a national network. It is funded by National Human Genome Research Institute, combines DNA biorepositories with electronic medical record, and is looking to leverage the high throughput genetic research to support implementation of genomic medicine into clinical practice. I regularly train practitioners. I actually have a course called Statin Overprescribing Solution, and I hope to see some of you in that course where we go through advanced biomarkers, monogenic and polygenetic determinations, as well as cardiac imaging to really personalize what needs to be done for our patients with dyslipidemia, either spare them a statin drug or use it in the lowest possible amount and actually understand what we should be using and whom and how. And I also interact with practitioners in our Holistic Heart University community, where we support their practice through a variety of resources, including webinars, presentations, opportunity for them to discuss, upload the case, relate to us any practice development issues. And actually, this is a little bit of an old slide because I recently added the AI practice tools that might be useful for your practice. I will stop here and allow Joanne to chime in with any questions.
Wonderful. Thank you so much, Dr. Drews. Great presentation. Just a reminder, everybody, we definitely have some time. So Dr. Drews covered a lot. So please, if there's any questions, you do have time to go ahead and type that in, and I will definitely ask. I do have two, and I will leave this open to you, Dr. Drews or Dr. Sedano, if you have any feedback on that. Question number one, is this type of testing meant to replace standard risk factor assessments for cardiovascular disease?
I'll take that one, and hopefully Dr. Solana will weigh in as well. Absolutely not. This type of testing is not meant to replace standard testing or even standard risk assessments for cardiovascular disease. This type of testing is meant to actually augment and transform our understanding how we can provide a risk assessment for our patients. The foundational risk assessment, though, the clinical risk assessment, the Framingham risk scores, they're here to stay. They're a great foundational starting point. And genetic testing is an opportunity for personalization of these more population-based metrics.
Yeah, thank you, Doctor. Yeah, this is Dr. Sedano here. Yeah, I 100% agree with that. And they do augment one another. They help one another so much. But the way I look at this is your lab test is your phenotypic expression. You can consider it that way. We're really seeing what is going on with the lipids. That's like the MTHFR. I like to have looking at the thymine, looking at homocysteine, looking at those levels. What are the expressions of these genes? So they complement one another. So yes, you would want to do both.
Thank you. All right, here's another question. Do high-risk individuals generally have a substantially increased genetic risk as compared to low-risk subjects?
So I'll start perhaps again, Dr. Sedano. So I'm assuming that the author of a question is asking about high risk being based on clinical conditions and, let's say, established risk schemas like atherosclerotic cardiovascular disease risk estimator or MESA calculator, or potentially even somebody who does not look bad on those estimates. Maybe they're low to intermediate risk or low risk, or has, let's say, some important family history. The answer is no. We cannot say that because people are at high risk clinically that they have high polygenic risk scores for the disease that they're manifesting the clinical risk for, right? There is no one-to-one correspondence because, as you had seen, there is a lot that happens between genetics and the clinical disease expression, and this is what Dr. Sedano just alluded to, right? There is a phenotype and there is a genotype. Yes, there are certain specific genetic variabilities like monogenic familial hypercholesterolemia variants that if the individual has them, especially homozygous, which means two abnormal copies, they will manifest disease, right? But those are not common at all. There are other ones which are much more common, but they are not necessarily aligned one-to-one with the clinical risk assessment.
Thank you. Dr. Drues, what are the imaging diagnostics you recommend? Coronary calcium scan or coronary CT angiogram?
I think starting with a coronary artery calcium score is a good place to start. It's very, very limited radiation, no intravenous contrast necessary. So I think these are fairly easy kind of low-hanging fruits. And the coronary artery calcium score has a very robust prognostic information bundled into it. And you can plug it in, for example, into a multi-ethnic study of atherosclerosis or MESA calculator, and it will allow you to refine the risk estimate for a patient on top of the usual culprits like LDL, HDL cholesterol, blood pressure, smoking, diabetes, and so on.
Thank you. All right, let's move on to the next slide.
All right.
If you can forward that. So just a reminder, everybody, this is Ask the Doctor. Any help with lab interpretation, questions on clinical conditions, reviewing of results, not sure of what type of labs to order. Left-hand side of your Avexia portal, Ask the Doctor. Dr. Sedano offers free email consultation within hours. We'll answer everything back in your Avexia portal. We also do provide live consultation for a fee, and that'll take you right to his Zoom link to go ahead and sign up. So again, just a great resource for any of these questions. And next slide, Dr. Drues. So now that we have learned about cardiovascular risk assessment, I would like to review how to order any testing mentioned in the presentation before concluding the webinar. First, you will need to log into your Avexia account and go to Avexia Link Ordering, which is located on the left-hand column of your dashboard. Then you will select or create a patient to assign the test to. Then you will select Specialty Labs. In there, you will find the drop-down box for Boston Heart Labs and select polygenic risk map, male or female, from the menu. And then finally, just complete the test order by clicking the green Place Order button. It's just that simple. And the last slide, I believe. For any questions, please contact Avexia Diagnostics by email at info@avexiadiagnostics.com or by phone 5 days a week at our extended hours, 8 a.m. to 8 p.m. Eastern Standard Time at 888-852-2723. Thank you, Dr. Drews and Dr. Sedano, for this informative presentation. A recording of this webinar will be available by email in the next few days, generally by Friday evening. If you do want the slide deck, we can certainly email that to you. You can email us at info@avexiadiagnostics.com if you have not been able to download that. And again, thank you for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and Boston Heart, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. Good evening, everyone. Bye-bye.
Thank you. Bye-bye.